Hello, I'm Donal McCauley and welcome to this Medics Voices conversation. Today I'm talking to Mercy Wanjala. Mercy's from Kenya and there's a very different health system there. So it's fascinating to look at how health system Kenya works and how primary care works. So let's take you back to the very beginning. Tell me how you got interested in medicine.
Um, Ever since I was a little girl, somehow I always knew I wanted to be a doctor. Whether it was because of my compassion for the suffering of others or a drive to just save people and make them okay, I always wanted to be a doctor. So all my life, I structured my education and my pursuits towards becoming a doctor. And finally, of course, that happened in around about 2008 when I joined the University of Nairobi and did my undergraduate program in medicine and graduated with a Bachelor of Medicine and a Bachelor of Surgery.
Tell us about medical school.
So, unfortunately for me, I didn't get directly to medical school with the 48 points. My points were less, but then there's another system called the parallel system where they give you a second chance to get into medical school. So that's how I got into medical school at the University of Nairobi. And medical school was quite different from high school because high school was, I would say, a little bit easy because it was just mostly testing recall, not testing your understanding and critical thinking. And that is what medical school was testing. So it was a bit different and it was tough, especially the first year, because we had like anatomy where you had to first of all get used to living with a dead body for 1 year, maintaining it, taking care of it, and then dissecting it from foot to head. So that was a new experience for me, but a valuable one at that. Also, we had to get used to reading and staying up, all nights. I remember most of the time I used to sleep maybe for 2 to 4 hours because unfortunately I could not get a hostel in the school because I was a parallel student. So I had to live at home, which meant I had to get like 2 buses or matatus to get to school. So that meant I didn't have much time to study and to sleep. So it was tough. Yeah, it was quite tough. So the first year, especially getting just the foundational subjects around medicine, physiology, biochemistry, and anatomy, and then ensuring that you pass them. And then every week we had what we called progress assessment tests, which you also had to pass. So it was constant reading and constant studying and dissecting and just going through the dead body to make sure you knew your anatomy well.
Yeah.
Yeah.
Let's move you on. Had you any experience of family medicine then as an undergraduate?
No, we had zero exposure to family medicine because family medicine had not yet developed or matured to that level. So we were exposed to various disciplines in medical school, starting from the third year of medical school, where you rotate in different disciplines like surgery, anesthesia, ophthalmology. So we rotated in all those disciplines and specialties, but not family medicine. We didn't even know what family medicine was or if it existed. So undergraduate, I had zero exposure to family medicine.
So then you qualify in medicine and you had a very interesting turn in the road. You went to Cuba. Tell us how that happened.
Yes. So after I qualified, I was posted to a county called Embu County. It's a peri-urban county with a large mass of rural area. So I worked there for about 5 years. And then this opportunity came up where the president wanted an initiative of training 50 family doctors in Cuba because he had gone there, seen the system, and thought it was a very good system and he wanted to bring it back to Kenya. So there was an intergovernmental agreement between Cuba and Kenya that 50 doctors go and train in family medicine, and then 100 specialists come and supplement the gap that was there in Kenya at the time. So what attracted me to the program, because at first I wasn't really for it, but what attracted me was once I read about Cuba and what it had to offer, I remembered the reason why I became a doctor, because I had been doing a program on in MBA healthcare management where we're learning about health systems, and one of the systems we learned about was the Cuban system. And one of the things that I thought, well, we're learning about all those systems, the people were nowhere there. We had subspecialized and over medicalized medicine to a point that we were thinking about body parts, we were thinking about how to fix them, but not the person it belonged to. So that's the reason why I thought to myself, I need to go back to general practice. The reason I became a doctor, looking after families. So that was in my mind. So when the opportunity came for Cuba, I just thought this could be a good opportunity for me to go get back to that. So I applied because it was one doctor per county. So I applied and I got the position from my county to go to Cuba.
Tell us a little bit about medicine in Cuba.
Wow, where to start?
Well, family medicine particularly.
Yes. So Cuba has this program that they call the Family Doctor and Family Nurse Program, which is the basis of their primary care system. So you have a family doctor and a family nurse taking care of a population of about 1,000 to 1,500 maximum. So all these patients are empaneled or are the responsibility of this team that is called the basic work team. Then we have a basic work group that is now a conglomerate of what they're calling consultorios. And consultorios is like a tiny small clinic where the family doctor and the family nurse see their patients. And then now we have the polyclinic, which links all these consultorios together and offers is a sort of hub that offers superior diagnostic capabilities that are not available at the consultorio. It also offers urgent care. So all like about 10 to 12 consultorios are linked to that polyclinic. And that polyclinic is called a health area. So the polyclinic plus those 10 to 12 consultorios form one health area, and everyone who lives within that area is linked to that polyclinic. So that is how people are empaneled or populations are empaneled from the small group to the large polyclinic. And then that polyclinic is also linked now to secondary care, whether it's an institute or a particular hospital. That polyclinic is linked to that particular hospital. So if any patient within that health area needs secondary care, they go through the polyclinic and to a specific hospital that polyclinic is linked to. So what is most fascinating is what the basic work team does. So what they do is what I came to learn now. People have a term for it. They call it population health management. But in Cuba, we just call it population, like control of different things within the population. So it was mostly focused on preventive and promotive activities rather than curative. So we would start by first of all knowing your whole population. That means within 1 year you have planned that each member or each family is visited once in their home and come once to the consultorio for a consult with the family doctor. So that you have to do. And then the second step after that is called dispensarization, where you have to classify your whole population according to their health status. And then once you do that, you plan their care based on their health status. First of all, the individual health status and then the family health status. And then that is how you plan their care. Then we had a number of different programs for everybody from the time they are a neonate to the time they age to the time that they are dying. We had a program for all that and for everyone in the community. The second thing that was fascinating about the work that the basic work team had to do is the focus on socioeconomic determinants of health. Because part of the assessment that we did with families, one was the functionality status of a family, to classify it as a healthy family that is functional, moderately functional, or dysfunctional. So once you classify that, you know which families are at risk and which families you need to pay attention to in terms of their dynamics, how they relate to one another, how they relate to the society around them. So care went beyond medical, went beyond clinical to the socioeconomic determinants of health. If you find someone in the or a family in the community that is economically deprived, you would connect them to social services where they get their food, their shelter, their clothing, and everything else that they needed, including their medication.
My goodness.
Yeah, so it went beyond just clinical and medical care to addressing the socioeconomic determinants of health, understanding that 70% of health and healthcare is based on behavior. So we did a lot of behavioral intervention and also behavioral care and also empowering the community around different behaviors that they needed to adopt to remain healthy.
Were you able to bring that back to Kenya, and how did that relate to the Kenyan health system?
So we are trying to bring that back to Kenya. I will admit it has been a struggle because, first of all, changing the mindset of a system that is set on diseases is very difficult because for ages Kenya has the healthcare system has been based on vertical program on reproductive and maternal and child health, HIV and AIDS and TB, different programs being managed differently by different people. So changing that mindset to a mindset of, hey, look, we can actually do this better. We can move to preventing and promoting health within the community so that we never have to get to this place. So it has been a difficult and an uphill journey. There are a few of my colleagues who in their counties have managed to implement just a little bit of what we've learned, but it is still an uphill struggle, considering also the fact that family medicine had not matured to a level that this would be easy to implement in the country. We're still at the stage where we're advocating for family medicine and family physicians in Kenya, the stage where we're telling people why family physicians at the primary care level. Because traditionally, primary care in Kenya was as not a concept, but a level of care, starting with dispensaries, then you move to health centers, and then you have the community health services. So that was considered primary care as per level. And the tragedy of this is that in 1978, we had the Alma Ata, which we quote very much, but nobody quotes the 1979 conference on health for all by 2000 that was funded by the Rockefeller Foundation, that told low and middle income countries, including Kenya that was in attendance, you cannot afford primary care as comprehensive as it is in the Alma Ata. You can only afford basic services, low cost interventions. So for 40 plus years, Kenya was focused on low cost interventions, basic services, which we call the GOPI FFF, which is growth monitoring and evaluation, immunization, um, uh, educate the girl child, food fortification, amongst others. So that is what people have considered primary care for a long time. So changing that mindset that has been frozen and solidified for 40 years as basic services, low cost interventions, to comprehensive services with a team headed by a family physician, of course, is going to be quite the uphill struggle and challenge. So that's where we are right now.
Well, your other interest now is in global health.
Of course.
Talk to me about that.
Yes. So as I was doing my studies in Cuba, I was looking for what I call a community of practice. I wanted to see which people are advocating for primary healthcare in Africa and then also globally, and which organizations I can join to also just find my voice and also find my place. So I joined organizations like the Africa Forum for Primary Healthcare, WONCA, which is the World Organization for Family Doctors, the World Medical Association, amongst others, where I learned how do you advocate for primary care? What is primary health care? What is primary care? What are the concepts? What are we advocating for when you talk about quality primary care? So that's how I found myself joining the global space, and finally found myself now as the executive coordinator of the Africa Forum for Primary Healthcare, where I'm leading various initiatives just to strengthen family medicine and primary care in the Africa region. And also with WONCA, where I'm involved in different working parties, still advocating for quality primary care.
Well, as part of these fabulous leadership positions, you have another role, and that was you worked with the IHI.
Ah, yes, I did. Yes. So also for a period while I was in Cuba, I applied for the IHI Open School, which was looking for what they call ambassadors for quality of care. So I applied and I got in, and I started working with them as one of the ambassadors at the IHI Open School. So what we did was, after learning these principles of quality improvement in healthcare, we would support different chapters of IHI Open School around the world in different quality improvement initiatives. So being the only coach, no, we're not called ambassadors, coach, who was speaking Spanish, I got connected to a group and a team in the La Universidad de Santander, which is a group in Colombia that was doing a lot of quality improvement initiatives and wanted to integrate the IHI courses into their curriculum for family doctors or family residents and also undergraduate students. So I got that opportunity to work with them, learn about the Colombia system, and see how they integrated it. And they are doing a lot of work in quality improvement in primary care through the IHI. So that was a good stint for me because one, I built my capacity in quality improvement and quality improvement techniques, learned how to coach people through quality improvement initiatives, and also developed my leadership skills in terms of leadership and organizing for quality improvement.
And finally, let me ask you, as we look to the future, about your work in futures.
Yes. So that is another place where I found a way of integrating some of the things I've learned in Cuba. So that's a consultancy firm where I consult in terms of health systems strengthening. So with that firm, we have done a number of work within the healthcare system in Kenya. Things like adopting, global health standards in health for health promoting schools. Because one of the things I had learned in Cuba was school health was part of primary care and a very fundamental part. So working on that project was very important for me, just to ensure that our schools are healthy. So, and other projects that we've worked on, of course, is community health services, strengthening community health services. Of course, also important for me to just integrate some of the things we had learned about community empowerment and community engagement in Cuba, which is a very fundamental part of primary care. So the work with Futures is consultancy, and that is another way I have found to integrate some of the principles I've learned into the policies that we are developing in Kenya.
Mercy, it's been an absolute pleasure talking to you. I've learned so much. Thank you very much for sharing African healthcare, Cuban healthcare, and your view of the future. Thank you very much indeed.
Thank you.